I am Glenn Moots, professor here at Northwood University and director of the university's Forum for Citizenship and Enterprise. And I'm very happy to see you here tonight, our last event of the semester. We're not competing with the World Series. What else have we competed against? Final Four. We competed against Final Four last time. We're competing, I guess, with the fog, but that's easily overcome. Now, for those of you who are new to our forum programs and you want to learn about our future programs, there's a sign-up sheet on that glass table right in the back of this room. Go ahead and put your name and your email on there, and I'll be sure to keep you updated on events. We're already working on the fall. We've got some great events for the fall. We owe a tremendous thanks to our co-sponsors, first the Institute for Humane Studies and the John Templeton Foundation. They've been our partners throughout this semester and also past semesters, and they are supporting tonight's event as well. They were founded in 1961 and are located in Arlington, Virginia. They advance a freer society by facilitating the development of students and scholars who share an interest in liberty. We had actually 2 IHS colloquia. We had 2 in the fall, we had 1 in the spring. We had over 50 students from around the state to discuss the topic of work and virtue. If you're interested in discussions of that kind, let me know. Dr. Matchak will be sure to let you know about future events. Also, IHS has a variety of outstanding summer programs. I think the application date for that may have closed, but that's also another great opportunity with IHS. Now, you got a survey, students, and IHS is very interested in your feedback on this event. They want to make sure these events are successful. They want to know what you think of them, and so please fill that survey out. Now, you may have filled out a survey for a previous event. Again, this is a separate event. Please fill that out. And we're also curious to know if you came into this debate on one side or the other, and whether Paul or John changed your mind. So that's always very interesting to me. It's kind of like voting as to who won. I always like to look and see if people were persuaded to go to the other side. So again, please fill that out, and I know sometimes faculty also make that important for any incentives that they've given you to be here tonight. We are also co-sponsored by the Manhattan Institute, which is a leading free market think tank focusing on economic growth and policy reform. The Manhattan Institute has been influential locally and nationally, including efforts, by the way, in 2012 and 13 to help Detroit police implement the broken windows policing, the same strategy that was used in New York City. And the Manhattan Institute fosters policy studies and publications that make a difference, as well as participating in programs such as our forum to influence entrepreneurs and business leaders of tomorrow. Tonight's debate is about healthcare policy reform, more specifically the Affordable Care Act, or Obamacare. Controversial since its inception, wildly popular with some, though despised by others, the Affordable Care Act became a central point of contention in our most recent presidential election. The ACA has changed aspects of both the insurance market and also healthcare itself. Its attempt to integrate market principles with government subsidies and mandates has endowed it with virtues and vices. It has earned the ire of those who have arguably lost their doctor, their coverage, and affordable premiums, but gained the allegiance of those who have gained affordable and reliable coverage, especially those previously considered uninsurable. I'm sure that you, like me, know people on both sides. Furthermore, healthcare spending now constitutes about 20% of our gross domestic product, and is one of the most significant policy changes in terms of its economic and political impact. And the recent failure of legislation to repeal and replace the ACA reminds us of why healthcare reform attempts under the Clinton administration failed, and why the ACA itself had a narrow victory. There are many, many constituencies involved in healthcare policy. There's a lot to untangle in healthcare policy, and unfortunately sound bites on cable news or the echo chamber of social media will not get us there. Now, our president has said, unfortunately without irony, nobody knew healthcare could be so complicated. Well, we've managed to find two experts who do in fact know how complicated healthcare is. And they're here tonight to debate the virtues and vices of the ACA, the Affordable Care Act. Speaking in favor of the Affordable Care Act on my left is John Freeman. John has worked throughout his career to bring about progressive policy change. To accomplish this, Mr. Freeman has worked with a variety of constituencies and coalitions and has directed campaigns to engage the public and build support for change. He understands the importance of these strategies from his time serving in the Michigan legislature. That was 6 years, right, John?
Yes, 3 terms.
Since 2013, John has been working in the renewable energy field to expand this sector by building a policy framework that supports this expansion. He is currently the executive director of the Great Lakes Renewable Energy Association, a trade association of renewable energy businesses. Previously, John was the Michigan State Director of Know Your Care, an organization that educated people and communities in Michigan about the healthcare reforms brought about by the 2010 Affordable Care Act. John served 3 terms as state representative in the Michigan House of Representatives from 1993 to 98, representing Royal Oak, Madison Heights, and Hazel Park, before being forced to leave due to term limits. Mr. Freeman also practiced law as an attorney at O'Connor and Associates in Detroit. He received his Juris Doctor from the University of Detroit Law School and his Bachelor of Science from the University of Michigan. Go Blue. He is a member of
Go Timberwolves.
member of the Michigan Bar Association as well as the Colorado Bar Association. He lives in Madison Heights with his wife and son. On my right, Paul Howard, arguing against the ACA, is Senior Fellow at the Manhattan Institute and Director of Health Policy. He is contributor to The Apothecary, the Forbes blog on healthcare policy and entitlement reform, and a regular columnist for the Morning Consult. Along with Peter Huber, he is the co-author of Unlocking Precision Medicine, published by Encounter Books, 2016. Mr. Howard has written on a wide variety of medical policy issues, including FDA reform, biopharmaceutical innovation, consumer-driven healthcare, and Medicare and Medicaid reform. He is often quoted on healthcare issues, and his work has appeared in such publications as the New York Times, Wall Street Journal, National Affairs, USA Today, and Real Clear Politics. He's a member of Manhattan Institute's Project FDA. Mr. Howard was part of the Healthcare Policy Advisory Group for Mitt Romney's 2012 presidential campaign, has testified 3 times before Congress, and during 2013-16 served on an expert panel as a judge for Celgene's Innovation Impact Awards. He joined Manhattan Institute in the year 2000 as deputy director of its Center for Legal Policy, where he edited research papers, managed legal policy analysis, and organized conferences. He holds his bachelor's degree from the College of Holy Cross and PhD in political science from Fordham University. And finally, I'll introduce our moderator. Our moderator tonight is someone that you will recognize better if you perhaps close your eyes when he speaks, because David Nicholas is producer and host for public affairs programming at CMU Public Broadcasting. He's been with CMU Public Radio and Television since 1990 in a variety of roles. He began hosting Meet the Candidates during the 2002 election year and took over Election Report in 2003. David was also part of or lead anchor for 6 election night coverage productions for CMU Public Radio. And if you've been with us for previous debates, you know David, and we're always pleased to have him here to moderate and also give me a chance to sit and enjoy it. Now, I'll say something about our format and turn it over to David. If you've been to previous debates, we're going to do things a little differently tonight. Our speakers will begin with opening statements. Each will have 20 minutes, should they decide to use the full 20 minutes, to present opening statements. Our moderator will then have the opportunity to ask questions for 15 minutes. And then we're going to turn things over to the audience. Now, when you came in, you had the opportunity to take a 3x5 card. This is your opportunity to ask a question. So during the debate, if you have a question, write it down on the card. And when we conclude with Q&A with the moderator, we'll move to Q&A with the audience. We'll have students who will collect your cards. Even if it takes you a little while to write it out, that's fine. We'll just keep bringing them to David, to our moderator. So please have those questions ready. We'll take about 20 minutes for questions from the audience. If things are really rolling, we'll take a little more time. And then we will move to closing statements from John and Paul, and that will conclude our event. Each will have 8 minutes. We hope you will agree with us that knowing one side of an issue really means not knowing it at all. And we look forward to your questions and participation. With that, please join me in welcoming David Nicholas, our moderator.
Works a lot better when he lays out all the ground rules. I don't have a whole lot then that I have to do to get things going. We can be somewhat flexible on the time, and that's not saying that the time structure is anywhere in error, but as we said, both guests will have up to that 20 minutes should they choose to use it. And when it comes to whether I take a full 15 minutes or not, we'll be flexible with that because we want as much give and take and exchange as we possibly can. Also, I guess I would say, and just to sort of re-clarify what Professor Muth said, at any point during their opening statements, during our exchange, whatever, if you have those questions coming to mind then, there is no right time, wrong time, or only time to be jotting down those questions. So make little notes, jot down a full question whenever it comes to you. That will be fine. I want to yield the floor to both guests after, once again, I thank Professor Muth and everyone here at Northwood for having me back over here this evening. Nice to take a break from the public radio fundraiser. We've got a few more days of that, and it's nice to have a break from that. I believe they probably did some sort of a coin flip, or the baseball bat, or rock, paper, scissors, or something to determine an order, but we are going to begin with the opening statements from the guest to my left. Would you please welcome for those once again, John Freeman.
Well, thank you very much, David, and thank you very much, Professor Muth, for inviting me. And I want to welcome Paul to Michigan. As your professor said, this topic is complicated. And so I want to encourage all of you to ask questions, because I want to make sure that this presentation this evening is something that you all find interesting and you learn something from this. You all should have a handout that I provided, which will give you something to take away with you that you can digest and learn from. And my email address is on a couple of those sheets. If you have any follow-up questions, you can feel free to email me whenever you want. To respond to the title of this debate, does America need the Affordable Care Act? I think the answer is absolutely yes, we do. And why do I say that? I say that because prior to the ACA, there was almost 48 million Americans that did not have health insurance. And now, since the ACA kicked into high gear, we have 20 million additional Americans that have been able to obtain health insurance. And so the results indicate that it's worked, and this has benefited our economy, and it's more particularly benefited the individuals. So my presentation I'm going to cover, I'm going to first start off with a set of principles I want to talk about for a couple minutes. I want to talk about the current outcomes of the ACA. I then want to talk about some of the key components of this law, how the ACA helps various constituencies, and then if I have time left over, I want to address some of the common questions that people have about the ACA. So let's first talk about principles. I think there are 4 principles that are key in this whole discussion. And the first one is the basic stuff that goes back to the Declaration of Independence, where our founding fathers indicated that we hold these truths to be self-evident, that all men are created equal. Well, we knew then at that time that all men and women were not created equal, and that statement still applies today. And it particularly applies in terms of health care, because if you have health care, you have a leg up on life. If you don't have health care, you're in a world of serious hurt. But the second principle is stated by my favorite Republican, President Abraham Lincoln. He indicated at the Gettysburg Address that we are dedicated to the proposition, this country is dedicated to the proposition that all men are created equal. What I take from that principle is that we have to work as a nation to continue to strive to become more equal. To me, this is a driving force behind politics, behind driving legislation to make our country a better place to live, work, and to raise a family. And this principle, and frankly, is what motivated me with my career in terms of trying to promote progressive social change. The third principle is something that I picked up somewhere along the way that is, quote, we determine who we are by what we do. And I think this applies both on an individual basis as well, frankly, on a political party. Because in fact, you determine what you believe in and what you are about by exactly what you do. And so I'm a Democrat. The Democratic Party passed the Affordable Care Act, and we have 20 million more Americans that have health insurance. Recently, we have a piece of legislation that was determined that would, in fact, take away 14 million Americans if, in fact, it was enacted. So to me, that is an indicator of where these two political parties are at. And my final principle is that it doesn't matter one iota how you frame a bill, how you describe that bill. It's all about the results of that bill. And so when I look at a bill and you hear all these grandiose adjectives to describe it, but the end result is taking away health care from 14 million people next year alone, and then more in subsequent years, that indicates to me that that piece of legislation is unacceptable and should not be enacted, which is exactly why I was very pleased and how it did not, in fact, get support. Okay, I want to now move to outcomes of the ACA. As I said a few minutes ago, 48 million Americans did not have health care prior to 2010. We have been attempting to get health care reform in this country long before Bill Clinton. We tried to get it with Franklin Roosevelt. It was originally a part of the Social Security Act. It was dropped for political reasons. Harry Truman tried to get it, failed. John F. Kennedy gave it a little bit of lip service, couldn't get it done. And finally, LBJ, Lyndon Baines Johnson, got Medicare and Medicaid enacted in '65. But still, we had a huge problem with the number of people without health care. But now we have it. And we have 20 million so far have gotten health care in the last 7 years. And what does that mean for those 20 million people? Well, fundamentally what it means, common sense. That if you get sick, those people get sick, they can now get prompt care. For those of us that have health insurance, that doesn't sound all that amazing, but if you don't have health insurance, that is amazing. It also affects the quality of your life in such a fundamental way. And I want to digress at this point, because this whole issue of quality of life should not be a function of whether you have money or not. Several years ago in 2012, there was an ad I saw in the Wall Street Journal. It was an advertisement targeted to people that read the Wall Street Journal. These are corporate executive types. The quote in the ad was, "When health is absent, wisdom cannot reveal itself, art cannot become manifest, strength cannot be exerted, wealth is useless, and reason is powerless." Now this actually was articulated by an ancient Greek physician, and this is in the ad. But the point of it is that this ad was saying to corporate executives, you should get the best health care coverage you possibly can get because it will make your life better, you'll make more money, you will be smarter, you will be happier. And I think that all makes sense. Who can argue with that? But the reason why the ACA is so important is because 20 million new Americans now can enjoy that quality of life that apparently corporate executives on Wall Street can, according to this ad. Third reason, if people have their health, they're much more productive at work. Businesses benefit from their employees that are healthy. People that are healthy are much more engaged in their communities. So this is much better for society. And maybe last but not least, people are much better off financially. Prior to the ACA, 50% of all bankruptcies occurred because of medical bills. Now that the ACA is in place and 20 million Americans so far have health insurance, they no longer have to worry fundamentally about going bankrupt because their son or daughter, their loved one got sick and they racked up a bunch of bills that they couldn't pay and they were forced to file bankruptcy. That fundamentally changes the quality of their financial life as well. Second set of reasons why the ACA is good is that it supports economic growth in this country. The fact that more and more Americans now have health insurance is a tremendous stimulus to the American economy. Now think about what would happen, since we all live in Michigan, if 20 million more cars were sold and bought in this country. We would see a lot more factories run by General Motors, Ford and Chrysler, Tesla, whatever, open up in this country. You would see a lot more auto workers being hired. There'd be a lot more wages that these folks would be receiving that they would be spending. It would be a total macroeconomic stimulus. The same thing applies in the healthcare industry. With 20 million more Americans so far needing healthcare, that means we're going to need a lot more doctors, especially general practitioners who are the gatekeepers for most of healthcare. Those doctors are going to have to hire more administrative staff. There's going to be more nurses hired. There's going to be more tech people hired in order to computerize the records for all these doctors. And so all this will be a macroeconomic stimulus for the economy, and the benefits will ripple out to the other parts of our country, our society that benefit from the healthcare industry. It levels, let's talk about how this helps business. This levels the field for large business. Prior to the ACA, some large businesses provide health care for their workers, their employees, but other businesses didn't. Arguably, it's an unfair competitive advantage if you offer health care and have higher overhead than businesses you may be competing with that chose not to offer health care. By this law requires all businesses that have 100 employees or more, they are required to offer health care. So this levels the playing field for large businesses. It also helps small businesses, because small businesses have a very difficult time competing for talent. Because if you're a small business and you don't offer health insurance, whereas a large business does offer health insurance, you know, if you're a normal functioning human being who cares about having health insurance, the chances are you're more inclined to go to the larger business because they have a wonderful benefit. The ACA enables small business to be able to afford to provide health care for their employees. If you're a small business with 25 employees or less, you can get a 50% tax credit of the cost of the premiums to help underwrite private health care for your employees. This means that if they can offer a benefit to their new employees, and from the point of view of the employees, if they're interested in working in a smaller business environment or a smaller business, they can. And finally, not finally, but another factor is free agents. There are lots of people in this country that don't work in a traditional employment setting. They want to work for themselves. They want to be independent consultants. You know, they want to be free agents. Prior to the ACA, the only option free agents had was to buy health care on the individual marketplace. But that is by far the most expensive marketplace to buy health care for. So many of these people that work for themselves could not in fact afford to do that. But now that you can buy insurance on the health insurance exchange at a reasonable price, and in a lot of cases get financial support, which we'll talk about, free agents now, independent consultants now, can do your own thing. You can run your own operation. You can do, you know, the gig economy, whatever the, you know, the latest vernacular is. So it gives you a lot more freedom to pursue your dreams under the ACA. What about hospitals? Hospitals prior to the ACA, if you received any federal money, hospitals were required by law to provide health care to anybody that walked in the door. And what that meant is that all these folks without health insurance would go to the hospital when they were seriously sick. But that is by far the most expensive way of receiving care. And those hospitals would have to eat the cost of providing that care. So that was called uncompensated care, and there was a huge amount of money in Michigan and around the country that hospitals had to swallow. If you're trying to formulate a business model for hospitals and you have to provide care and don't get paid for it, it really undercuts your ability to run a well-functioning hospital system. That is why the Hospital Association totally endorsed the ACA, because they knew that they will get a lot more customers in their door that can actually pay for the service they receive from the hospitals. And this has strengthened the hospitals considerably around Michigan and around the country. And the final thing on the economy and economic growth is something called job lock. You know, prior to the ACA, if you did work for a business that offered health care, and you really didn't like the business, and you looked around and you realized that there was no place else to go that would pay a decent salary and offer health care, a lot of times you just sucked it up and stayed with that business because you had a family that provided health care. And so that was what's called job lock. But now that you can get health insurance on the exchange, you're not necessarily stuck in that situation. You can leave and be able to get health care in a very affordable way. And finally, insurance companies in the economy has done extremely well under the ACA. If you look at how the stock market has performed since 2010, the healthcare stock industry, insurance industry, has gone up about 300% in the last 7 years, whereas Standard & Poor's, the normal economy stocks, have only gone up 135%. United Healthcare, which is one of the big ones, has in fact gone up 480%. So the ACA has also been good for the insurance industry. Let's move on. Key components of the ACA. There are basically 3 prongs to the foundation of the ACA. The first one is that requiring all people to have to obtain health insurance. It's called universal coverage. Everyone in, nobody out. The whole point of this is to eliminate what's known as free riders. People that didn't have health care before, but when they got sick, they would go to the hospital knowing they would be able to obtain care. And that caused serious problems. One of the reasons why it's a serious problem is that hospitals would also try and recoup some of this cost by charging more to people that in fact had health insurance. So every business, every person that provided health care, they are paying, prior to the ACA, they were paying more than they should be because the insurance industry, the hospitals are passing the cost on to other folks that in fact had insurance. And so that was a huge problem. By requiring everybody to get insurance, you go after the free rider problem. The other reason why universal health care is very important is that you increase the pool of insurance. The way insurance works in the private sector is that you want healthy people paying in their monthly premiums, and at the same time, people who are sick are drawing from that pool of money. And so you need to have that balance. And so you need to have people paying in when they don't need the care, so that when they need the care, the money is there for them. And so by having the universal requirement for insurance, it greatly expands this pool of money. So what does this mean then, if you expand the insurance market for insurance companies? This means that now insurance companies, this is the second leg, should no longer discriminate against people with pre-existing conditions. Prior to the ACA, it was perfectly legal for insurance companies to discriminate against people who were sick. Diabetes, cancer, serious illnesses that most people had no control over, they could not get insurance. And it was perfectly legal for the private sector insurance industry not to provide insurance for them. And that obviously, at least in my opinion, is fundamentally wrong. But if you require everybody to get insurance, so you're guaranteeing the market for the insurance industry, the quid pro quo is no more discrimination against people with a pre-existing condition. And the insurance industry agreed to that during the run-up to the enactment of the ACA. The other things the other requirements now is that insurance companies can no longer drop people who actually draw upon their benefits. That was another common thing that occurred. You have your insurance, you paid every month, then you get sick. You start paying your hospital bills or your doctor bills, and all of a sudden the insurance industry says, you're done. We're dropping your coverage. We're not going to pay any more for your sickness. Again, perfectly legal, but no longer legal under the ACA. The other fundamental requirement is that now we require all insurance policies to contain basic essential benefits. So it's a quality package of benefits that every private sector insurance plan has to offer. The third prong of this is that, okay, if you require everybody to get insurance, and then you require the insurance industry to no longer discriminate against people with pre-existing condition, you now have to enable people to be able to afford to buy the insurance. So how do we do that? The first thing we do is we tackle working families, low-income people. We do that by expanding Medicaid. Medicaid was enacted in 1965 to directly address the fact that low-income people could not afford to buy insurance. And so 1965, under Lyndon Baines Johnson, they enacted Medicaid. So now the lowest, prior to the ACA, the lowest of low-income people could afford to get it. What the ACA did was to expand the income eligibility. So now it's about $16,000 for an individual and around, I think, $32,000 for a family of four. If you fall in that income range, you now can get insurance in Michigan under the Medicaid program. And the federal government, under the ACA, provided a tremendous amount of federal money to the states to provide this insurance. And that is also a contributing factor to the macroeconomic stimulus, because what this money represents is our tax dollars going to the federal government, but now we're seeing a lot more of our tax dollars coming back to Michigan to provide health care for lower income working people. And so it's a great thing because, again, you're providing insurance, you're providing increased quality of care for people, but you're also supporting the economy. The second end is middle class. So what the Affordable Care Act does now is provide a tax credit subsidy for people in the middle class, the income level right above Medicaid. So now, under the law, if you're an individual and you make between $1 more than the top level of the individual for Medicaid, around $16,000, up to about $47,000 as individuals, or between $32,000 and about $97,000 per family of four, on a sliding scale, you now can get tax credits from the federal government to help you pay for this health insurance. And again, this money is from the federal government you pay in taxes. Okay, I've only got 2 minutes left. So I want to quickly talk about the health insurance exchanges. The health insurance exchanges is the mechanism from which that people can buy insurance. There are 4 levels: bronze, silver, gold, and platinum. And they range in terms of the benefits that are offered, but all 4 have to offer the minimum essential benefits that I initially talked about a few minutes ago. And these are offered on the exchange. The goal of the exchange is also to promote competition within the health insurance marketplace. Michigan has a lot of insurance companies that are playing on the exchange, and they have to provide this information to the state of Michigan. It's open and transparent. So for the first, and these plans have to be written in normal, simple English in the same basic format. And so the idea is that consumers and small business can look at the various plans being offered on these exchanges, compare and contrast, and decide which plan benefits them the most. And so we're seeing some serious competition. It has kept down prices, and it has been effective. Now, I did not get to, frankly, a number of things which I hope will come out in the questions. I haven't talked about how this benefits various constituencies, so I hope we get to that. I haven't talked about some of the common questions that you hear about regarding the ACA. And some of the common questions I hope we get to is, are insurance companies pulling out of some of the state markets that you hear a lot about? Are insurance premiums going up? That's another common issue. Are healthcare costs going up? And the big one probably is whether the ACA is in fact a government takeover of insurance. So we hope we get to these issues. But I want to conclude by again saying that I want all of you to ask questions so you all can learn as much as you can by this, and I look forward to what you have to ask. Thank you very much.
Thank you, John. Okay, well, just a brief transition then. And so from his comments, if you already have the beginnings of questions, fantastic. Some of those points that he made could be the basis for some of the questions that you will be coming up with. We also want to now turn over the platform to Paul Howard for his opening statement. Paul?
I'd like to thank Glenn and John, obviously, and David for making the event possible this evening. I'd also like to thank Northwood University for making this whole event possible and hosting us this evening. You know, I never thought I'd hear a progressive praise higher profits for the insurance industry, but I guess healthcare makes for strange bedfellows. As you've heard tonight, I'm going to argue that America doesn't need the Affordable Care Act. And I'm going to argue that not because I don't think we need health care reform. As a matter of fact, I still think we do. We needed it before the Affordable Care Act passed. We need it today. We're going to need it even more so over the next couple of years. I'm going to make a point that's a little bit orthogonal to what John was talking about. I want you to keep in mind throughout the course of my remarks that health and health insurance are different things. Health insurance is a financing mechanism, like every other kind of insurance, for financing high-cost, rare events. Health is what you have every day, and you can have health without having health insurance. Health insurance is that financial protection. We're going to talk a little bit more about that. I'm going to make 3 points today. The first point is going to make is that, again, health insurance does not equal good health. It does not equal good health outcomes. I'm going to tell you what the ACA does and doesn't do. And last, I'm going to tell you where the ACA exchanges are today and where they're heading, and a few things I think we can do to make healthcare better and more affordable for all Americans. Bottom line is I'm going to tell you why we don't need the ACA. We need something much better. We need a program that provides affordable care at real prices to all Americans that's higher quality. And that gives us more money to spend on all the other things that we care about, because health care is not the only thing that we care about. We care about more jobs. We care about better homes and better houses. We care about having more money to spend on leisure time, a whole host of things that we care about. Our biggest problem in the US is not the lack of health insurance. It's what we talk about. Because there is a segment of the population that doesn't get health insurance through one of the tax-advantaged ways that we've created to funnel dollars to the healthcare industry, either through employer-provided insurance or Medicare or Medicaid. There are people who fall in between the cracks. It's less than about 7% of the population. People who have pre-existing conditions or are too poor to avoid buying it on their own. But one of the reasons they can't afford it is it's simply too expensive for people to buy without tax assistance. But there's a funny thing about subsidies. Subsidies make the thing you're trying to buy more expensive. Think about it in your own context as a college student. Look at college tuition. Where has college tuition gone over the last 2-3 decades, right? It's enormously expensive. At some places, $60,000 a year and up. But we have student loans. We have low-cost and no-cost student loans. Students can take out lots of loans. What's the natural response of an industry that faces a customer who doesn't really care what the price is and it's being subsidized by someone else? What has the industry done? They've raised their prices. For people who have Medicare coverage, for people who have employer-sponsored insurance and think that someone else is paying, what has the healthcare industry done? They've raised their prices. When we subsidize something and don't give the person who's using it a real reason to think about what the marginal value is, not that it doesn't have value, but is there a way to do this more efficiently, effectively, at lower cost? That's what the other 4/5 of the American economy do, right? People compete for your dollars, for your phones, for your computers. They find out ways to chase you down and tell you what the quality of their product is and what the price is, and then they compete to lower it over time. That is not the US healthcare system. Today we spend close to 20% of US GDP, or $3 trillion, on healthcare in the US. If we just sliced off the 2 largest government programs, Medicare and Medicaid, Medicare for the elderly, Medicaid for low-income Americans, the U.S. would be spending more than almost every other nation, wealthy nation in the world on healthcare. We'd be in the top 5, easily, just those 2 programs. Experts on both the left and the right agree. About 20%, at least 20% of U.S. healthcare spending, in other words, $600 billion, is spent on wasted, ineffective, or fraudulent care. At least $600 billion. Even in Washington, D.C., that's real money. The ACA, however, the President and the Democrats looked at this situation and said, okay, we have this dysfunctional system. We have incredibly high spending. Healthcare spending keeps growing faster than GDP growth, than wage growth, what you're taking home, than inflation, everything else. It's outstripping everything else. What are we going to do? We're going to create a new subsidy stream. I'm not saying that it's not fair that people who have employer-based insurance get a big tax subsidy and people who don't have that benefit don't get it. It is unfair. It is something we need to do something about. But by not focusing on cost control, not getting consumers even more engaged, and I agree, the marketplaces are a start to try and get people looking at what the marginal benefits and costs are. We'll talk about why that isn't working well in a minute. But what the ACA has done is some people, low-income people, people with pre-existing conditions, get very generous subsidies. Care is basically free to them. But for everyone else in the pool, costs have gone up. And if you think about health, your health, which is something you're probably not thinking about being in college, because poor health and illness becomes much more prevalent as you grow older, right? Your biggest risk factor for becoming sick is becoming old, right? Aging. Your risk of chronic disease shoots up. So if we raise the cost for most people who are healthy most of the time in that individual market, most of them are going to sit it out. Median healthcare spending in the US per person per year is only about $800. So if you tell someone, we're going to have a mandate that requires you to buy health insurance, it's going to cost several $1,000s for a year, it's going to have a deductible, it's going to be at least $5,000, up to $14,000 for families. And that's all going to be out of pocket before you get $1 of insurance coverage. Most of those people have made the rational decision to sit it out. I'm not saying that there aren't winners and losers under the ACA. I'm saying we've taken a situation that was unfair and made it more unfair for other people, rather than solving the underlying problem. A wealthy nation like ours can find a way to use competition and choice, and yes, targeted subsidies for the people who need help the most to bring down costs. So I'm going to make the case today that America doesn't need the ACA, it needs something much better. And by the time I'm finished my presentation, I hope you agree with me. I'm going to say something heretical again. Health insurance, health care does not equal good health. Liberals like to point out that America doesn't get the same outcomes as other wealthy nations with universal health care, like the UK or Canada. And they point to statistics like longevity, how long you live. In the US, average lifespan is about 78 years old. Okay? Women are a bit higher. You look at other countries, they live longer than we do. The funny thing, though, is a lot of other things affect your propensity to develop a serious illness and how long you live. It's actually difficult to tease out the effect on health insurance on measured health status. What do I mean? What goes into health? Think about it. Diet, exercise, accident rates, rates of violence, and of course, rates of teen pregnancy if you're looking at issues like infant mortality. The US's population, which is both more ethnically diverse and economically diverse than a lot of other countries that are more racially, ethnically homogenous, plays against us. A 2006 survey from researchers at Harvard University called The 8 Americas really highlighted this point beautifully. They found that Asians in the US live the longest of any ethnic group. But they also found that Asian women living in Bergen County, New Jersey, live longer than Asian women in Japan by 3 years. 91 years in Bergen County, New Jersey compared to 88 years in Japan. Is there a fountain of youth in Bergen County, New Jersey? I don't think so. They also found that young and middle-aged African Americans living in urban environments had poorer health outcomes, but so did whites living in Mississippi and rural Appalachia. Lower income whites living in mid-plains states and the Dakotas live longer than middle income whites living elsewhere in the country. Scandinavians in the US live longer, earn more, and have better health outcomes compared to other Americans. What is going on here? The fact of the matter is that real health outcomes are very complex. They're about culture, they're about behavior, they're about the environment you grow up in. So if we recognize the complexity, how do we spend money that actually has an impact on these measured health outcomes? Medicaid spending, our program for the poor, is a great example of this mismatch between what we need to do to improve health outcomes for some of the most vulnerable citizens and how we actually spend our dollars. A 2015 study from researchers at MIT and Harvard found that the value of the Medicaid program to actual Medicaid enrollees was about 20 to 40 cents on the dollar. What does that mean? Most people who were low income had relatively low healthcare expenses, right? So the value of providing them comprehensive insurance wasn't that high. It didn't mean it didn't have any value, but for people who don't have high expected health costs, it doesn't have that much value. Guess where the US spends most of its safety net dollars? Is it on housing programs? Is it on supportive housing for the mentally ill? Is it for prisoner reentry? Where is it? It's on Medicaid. My colleague Warren Cass did a study last year that found that over the last 3 decades, the US has funneled 90% of its safety net dollars to healthcare programs. If you're a low-income American, you might prefer to have more money through an earned income tax credit or a housing voucher or money for education, or any other thing that have been proven to show better health outcomes. As a matter of fact, those other nations that my liberal friends and colleagues point to that have better health outcomes actually spend more on social programs relative to healthcare spending than the US does. We have an automatic ratchet through our Medicaid program, where basically for every $1 the states spend, the federal government sends $2 sloshing through their economy. This allows wealthier states like New York to spend much more on average and have richer benefits. But it doesn't have any effect on these measured health outcomes. On average, spending more doesn't get you better health. The imbalance between how we think about health and health insurance leads us to neglect all the other things that are important to us. Let me talk for the second point again, what the ACA really does. Back in 2009, President Obama and Peter Orszag, who at the time was his Director of Management and Budget, said healthcare reform is entitlement reform. What they meant was that healthcare spending is taking over the federal budget and, of course, state budgets. 60% of federal revenues are going to healthcare programs. At the state level, healthcare is either the fastest growing part of the budget or the #1 budget item. It's crowding out spending, again, on everything else we want to do. If you are liberal and you want more spending on education, or you want more spending on income supports, you've got to fix healthcare reform. You've got to lower the rate of healthcare cost growth. You've got to get better value. If you're a conservative and you want tax reform, you want lower tax rates, you want faster economic growth, maybe you want to spend more on defense spending. The only way we can accomplish any of those liberal or conservative priorities is to lower the rate of healthcare cost growth and get more value for every dollar that we spend on healthcare. What does the ACA do at a fundamental level? According to the Congressional Budget Office, over the next 10 years, that's from 2018 to 2027, it's going to spend an additional $1 trillion with a T on Medicaid, and close to another $1 trillion on premium subsidies and cost-sharing subsidies on the marketplaces, on the exchanges. We're also going to spend well north of $40 trillion on all other healthcare we provide. The Congressional Budget Office also noted that when all is said and done, when the ACA is completely implemented, there will still be 27 million Americans without health insurance coverage. So we're going to be spending an additional $2 trillion over the next 10 years to lower the US's uninsured rate from 15% to 10%. I'm not saying it's not important to give people who don't have access to these other programs an opportunity to buy it. I'm not saying government needs to get out of the business of healthcare. There are always going to be people who need assistance, who are either extraordinarily sick and therefore need high-cost care and can't afford it for themselves, or for some other reason don't have access to it. The problem is that we haven't designed a system where we really know the quality and the cost of the things that we're buying, and individuals don't get to make the decision about everything else that you do in your life, whether you decide, to spend an extra dollar on getting a better car or better housing, right? For all the other critical needs in your lives, we rely, for the most part, on the markets to provide those things. Other critical needs. What are the other critical needs you could think of? Food, housing, right? All of the things in your life that are really critical to your health and well-being, we let the market provide all of those things. And we provide targeted help to the people who most need it, but we don't say, we're going to tell everyone what package of things they have to buy. People may not, I know there'll be some concern about this, they may not make the decisions that we would want them to make. But they're also not going to eat vegetables at every meal, exercise 30 minutes a day, or do any of the other things that we know can improve health status in the long run. The Affordable Care Act, and this is the last point I'll make, where the exchanges are today. The Affordable Care Act basically looked at a population, the 44 million Americans who didn't have insurance in 2008, and said, we're gonna provide coverage to these, we're gonna attempt to provide coverage to these populations. Who were those people? About a third of them made $50,000 or more, right? They could afford insurance, they just didn't want to buy it. Another third were eligible for public programs like Medicaid, but just didn't bother to sign up. And this is one interesting thing, that John pointed out. He said, in the Congressional Budget Office score of the Republicans, not even repeal and replace, kind of like repeal plus act, that 24 million additional Americans would go uninsured. The CBO noted that, but they also noted that about 5 million Americans would drop out of Medicaid, a free program, a completely free program, because the federal government wasn't threatening them with a mandate to buy it. The people who most needed our help, and the Kaiser Family Foundation did this study several years ago, about 18% of the people in the individual insurance market had serious pre-existing conditions and were denied coverage or couldn't purchase it at an affordable rate. It's about 8 million Americans. So we've taken those 8 million Americans and the rest of the population, the 36 million Americans who are not in that bucket, who are rotating in and out of the individual market. Remember, the individual market is people who are 28, 29 years old, out of college, at their first job, maybe not have insurance, but then in 10 years they're going to be married, they're going to have a job, or 5 years, they're going to get coverage. People move in and out of this market all the time. So what we did was we said, here's an expensive product, we're going to require you to buy it, but for people who have these low expected costs, they're going to look at this, and they have, and said, I'm just not going to buy it, it's not worth it to me. The IRS projects that 6.5 million Americans are paying the mandate tax rather than buying insurance because it's just not worth it to them. So what's happened on the exchanges is the people who the insurers most need to be in, young and healthy people with low expected health costs, are staying away in droves. Insurers expected about half, 44% of the people in that market, to be young and healthy. The steady rate under the ACA has been 27%. The exchanges are bleeding red. 4 out of the 5 largest insurers have either, like United Health, like Aetna, have either pulled out completely or have sharply cut back. And this is not just red states, it's red state and blue states. It's Arizona, where Blue Cross Blue Shield, the insurer of last resort, is considering pulling out. It's United Health that cut back on the exchanges after losing nearly $200 million. It's in Minnesota where Blue Cross Blue Shield lost $265 million. The insurers are going back to the Trump administration saying, look, we're not going to stay and play in this environment. And John mentioned the stock values of the insurance companies. The stock values went up largely because there's been an expansion in Medicare Advantage plan, which is another subsidized part of government coverage for Medicaid patients, and because there was a Medicaid expansion. So Medicaid managed care plans are making a killing, making a lot of money in this market. I think we need a different set of solutions. I'll just conclude with this. We need a market where prices and quality are transparent, where the government stops being a co-pilot for industry, an industry where over 200,000 Americans die every year because of medical errors. Think about that. It's one of the leading causes of death. Why is it that we haven't eliminated these preventable medical errors? The FAA, which regulates airline safety, hasn't had an airline fatality in something like 20 years. The FAA is just in the business of protecting safety. That's all they do. The government should be in the business of targeting subsidies to people who need it most and ensuring there's price and quality transparency. Because when we bring down the cost of healthcare, more people can afford it, our governments can afford it, and we can spend more money on all the things that, as liberals and conservatives, we all agree on. Please join me in voting against the Affordable Care Act, because we do need something much better. Thank you.
In the past, we, at the prior events that I attended, we would open up a period now where we would have had one questioning the other, and there would have been a time limit. And I'll sort of look for a nod or a no from Glenn. What I might do is ask a few questions here and direct them one side or the other, and give 90 seconds or 2 minutes. Which do you prefer? And then you want 2 minutes and 1? Do you want 90 seconds and 30?
90 and 1.
90 and 1. So if we ask a question to one, they'll have 90 seconds, and then the other individual would have 1 minute to respond, and we'll try to bounce these back and forth. So I say that for the benefit of AccuTimekeeper. We're good? Since me counting that, we don't want to go down probably that road map. So I'm going to begin trying to keep this in the order of exchange. And it's sort of a broad question, but it is one of the leading criticisms that comes up, so I will address this to Mr. Freeman first. And I put a star next to this. Going through, people say, well, who's paying for it? And the question of sustainability. It is providing coverage, yes, to a lot more people, but if we look at the basic element of, at the end of the day, who is paying for this, and is the method of paying for it sustainable?
The ACA provides a mechanism to pay for the expansion of healthcare. Because it's a guaranteed market for the insurance industry and the drug industry, because everyone has to sign up for health insurance, the insurance industry and the drug industry and the medical industry all agreed that they would pay more taxes and more fees in return. So these additional taxes were voluntarily agreed upon during the negotiation prior to the enactment of the bill, and that helps to finance the expansion of the Affordable Care Act. In addition, the U.S. government is instituting ways to try and save money. Right now, when I mentioned earlier that hospitals prior to the ACA had to provide lots of uncompensated care, one of the ways they survived is that the federal government would give them specific subsidies to help them overcome that budget deficit. Now that people have insurance and can go to hospitals and pay for it, the government is cutting out these so-called dish payments. And finally, the taxes for Medicare now have increased for higher income people. Now unearned income is being taxed, whereas prior to the ACA, only earned income, which is wage income, was taxed. Unearned income is like stock bonds and those types of revenues. So the ACA has the mechanism to pay for itself. I don't think I have enough time to answer the second part of the question, but we can continue later.
Yeah, we may come back around to that point. Your response.
Thank you. You know, it's funny, and I'll just say a couple things quickly, one of which is if every part of an industry comes to the table with the federal government and says, oh, we're willing to pay a tax if you give us more business, I think that the industry thinks that it's making out really, really well. And if the fundamental problem is we need to lower healthcare spending and get more value, I think we need to look elsewhere because, competition for other industries, is painful, right? When you look around at hospitals, and I know that some safety net hospitals are struggling, subsidize the people directly. There was about $50 billion in dish payments, these uncompensated care payments before the ACA. Now we're paying in excess of well over $100 billion annually. So look, the hospital industry is making out very nicely. If you look around the U.S., about 80% of all metropolitan areas in the U.S. are really heavily concentrated in terms of hospital market power. They're consolidating, they're getting bigger, they're using their market power to raise their prices. And then, look, there's about $40 trillion in unfunded liabilities for the government, right, for healthcare and everything else. That's not under control. That's the thing that's going to make it increasingly difficult for us to do anything else.
We'll come back to you, Paul. Then we see countries, and we hear about this, and we've been hearing about this for years. In the UK, everybody's got coverage. In the Netherlands, everybody has coverage. These people are happy. This is what we've all been told. And critics at the same time are saying, yes, but everybody is taxed to the hilt to get this. Better outcomes with provided coverage, you say, are dependent on lifestyle choices. And how would you compare the economic standing of those countries? I don't want to get too many layers into the question, but how do we get better outcomes with the provided coverage that we've had versus those who already have a quote-unquote universal coverage?
Right. I mean, when you look at, like Japan has the world's lowest rate of cardiovascular disease. Again, it's not because they have these fantastic surgeons or hospitals, it's because they have different diet, different genetics. Every country has a different system, right? The US is going to have a different system. France has a different system than the UK that has a different system from Canada. I think if we level the playing field and give more of this money directly to individuals, they're going to make decisions. Is this really worth it to me? Markets don't exist unless there's someone who's willing to pay for it and make a decision about, at the end of the day, is this really worth it to me? So I think that that's more what we need of. Actually, in a lot of countries, like say Switzerland, they have higher out-of-pocket payments than we do here. That's one way to get providers more focused on value.
Your response, John?
Well, those systems in Europe, they're mostly government-run health insurance systems. And so they are much differently operated than the American system. Paul indicated during his opening comment how excessively expensive healthcare is in this country, and that's absolutely true. One of the reasons why it's true is that the administrative cost for private sector insurance systems is much more expensive than when you have a government-run system. A good example is the VA system and Medicare, where the administrative cost is around 2%, whereas the administrative cost for the private sector is 15 to 20%. In Europe, where it's government-run insurance, the administrative costs are much lower, so that's a lot less money being spent for healthcare than it is in this country. And in addition, those countries in Europe, they negotiate prices for drugs, whereas in this country, we have no current capacity to negotiate lower prices for drugs in America as they have in Europe. And so we pay a lot more for drugs, a lot more for medical procedures, because we don't have the same type of government regulation that they have in Europe.
Just a brief reminder then, if you haven't already jotted down a question, be thinking about one as from the statements that they gave and also the Q&A that we're doing here, because we do want to open it up to the floor here in the next few minutes, and I'll wait for a high sign as to when anybody would like me to, and turn it over to all of you. One thing, John, that you said you definitely wanted to address and did not have the time to do so in your opening comments. I put a star by this too. One of the fundamental questions, criticisms that's out there that you wanted to specifically address, the question, are premiums going up? Your chance to address that now for your 90 seconds.
The answer is absolutely yes, they're going up. But they're going up at a lot lower rates than they were prior to the ACA. Secondly, you have to understand that the state insurance commissioner in every state in this country, they decide on whether rates go up or not. When an insurance company in Michigan wants to raise their rates, they have to submit a proposal to the state insurance commissioner, and they're the ones that decide. So last year in Michigan, the insurance companies in Michigan asked for about a 17.2% on average increase in premiums. And the Republican state insurance commissioner granted 16.7%. If you wanted to keep premiums down, the insurance commissioner should, I would argue, do a much better job at examining just why they want to have, on average, a 17% increase. There's no doubt, going back to my earlier point, that there's a lot of waste and fat within the way these insurance companies operate. And so if we had an insurance commissioner that was doing their due diligence and examining why the rates, why in such a humongous rate, maybe they would have a lot lower, they would grant a lot lower rates. The analogy is that when a utility wants to increase the electric rates or gas rates, they have to appear in front of the Public Service Commission. And the Public Service Commission in Michigan does a pretty good due diligence job. We need the same kind of active analysis by the insurance commissioner, and I don't think we're getting it.
A response?
The insurance commissioners, what they do is they look at, an insurer's payout. So how much are they collecting in premiums? How much are they putting out in medical costs? And the exchanges as a whole have been underwater almost since their inception. There have been attempts, there were two mechanisms that are called reinsurance and risk corridors that were meant to protect the insurers who are operating on the exchanges. They've expired since last year. Rates went up by 24%. At the end of the day, the administrative costs of the insurers are low. You look at Medicare, which does have lower administrative costs, but the problem there is they don't monitor any of their spending. And Dartmouth University and their researchers there have said there's enormous variation in spending in Medicare across the country, not just across states, but within states where hospitals have widely different payments for the exact same type of patient. So we actually need higher administrative costs to cut down on waste. The thing that other countries, just to respond to one of John's points, have in their advantages, they capped prices back in, the 19th century where they started these universal systems. So if you keep your rate down over time, you can hold the base down. Their healthcare costs are growing at about the same rate of ours because we're all aging, and aging people need more care.
Before I go on with a couple of more points, do we have any of those questions gathered up by those that are helping Professor Moots? Some of those can make their way down here. Somebody can...
Yeah, if you have a question, just hold it up.
Yeah, you got it, and they can collect those and start bringing those down. A couple of more points then, and we'll send this first in the direction of you, Paul. A criticism that a lot of people say in the midst of all of this argument, both ways or the other, is that there is a group that has not had to make any change in the healthcare, and that is lawmakers in Washington. And you were talking about, in overall terms, how we address the gap of those with, those without, and yet those that are passing the laws in the end are those in Washington. People go so far as to say then, well, let's see them take a cut in coverage and let's see them do without, et cetera, et cetera, et cetera. How would you address then that gap to what seems to be their rate of coverage versus what's available for everybody else?
Look, I'm not particularly incensed about the idea that the Congress hasn't been moved on to the Affordable Care Act exchanges. If other people are very concerned about that, they can kind of make that point. What I'd say is, the fundamental sin of American healthcare, if there is one, goes back to World War II, when the IRS told large employers that you could offer healthcare as a fringe benefit. It wasn't going to be taxed because millions of Americans were abroad fighting in World War II, and companies had to have some way to compete compete for labor because they couldn't raise, their prices for their products. They were price controlled. So they started offering this as a fringe benefit. It got enshrined in law, and we've been on this roller coaster basically for years. The actual largest tax expenditure the government has is for employer-provided insurance. It's regressive, it's unfair. We need to find a better way to make it more equal for people to access insurance.
It's interesting you bring that up because there was an article I kept from February of 2011. Maryland Representative Andy Harris caused an uproar during freshman orientation when he demanded to know how long it would take for his federal health insurance policy to kick in. So you're absolutely right. It's always fascinating when you have people in power or rich people always saying why we don't need health insurance for lower income people, but when it comes to themselves, they always want it quickly and they want the best. Secondly, the ACA, Congress made a decision to try and improve the healthcare system by building upon the current private sector employment-based system. The other option is a single-payer system, which is what England has and some other European countries. But politically, it was a non-starter in this country. So the decision was made to try and improve the current system. But Paul is right that the current system is full of inefficiencies and fat and waste. And a key part of the ACA, which we haven't even talked about, is the fact there are all sorts of cost controls and systems being put in place to try and address the high cost of healthcare. One final comment is that currently in France, it costs about $4,463 to get your appendix taken out. In this country, it's about $13,851. So there's a lot to be addressed in this country, a lot of reasons why healthcare is expensive. But the ACA is the first serious effort to try and address not only we need to expand coverage for working and middle-class Americans, but also to try and address the high cost of healthcare. But in order to do it, you have to work with a political framework that we all operate within.
I'm going to move on to some of the questions now that have come from you. If there are more, then just raise those cards in the air, and those that are collecting them, we've got a handful. We'll go through, I would think we've got time for all of these. We'll do our best. If you have additional ones, please continue to jot those down. We will shift it back over first for the 90 seconds initially to John. And the question reads, history has shown how inefficient and wasteful government is when it has control over industries that were once privatized. Example, I'm sorry I'm not being able to make quite this out, but we'll let it go at the general privatized systems. Why would the government controlled healthcare industry be any different than this track record? Your 90 seconds first to address that.
Well, first and foremost, the government is not controlling what the insurance companies or the hospitals per se are charging. They're more saying that you have to provide insurance, people have to get insurance, that's true. They're saying that the insurance industry has to provide 10 essential benefits, that's true. But they're not saying how much they charge. The government is laying out a regulatory framework from which the private sector insurance industry, doctors, have to operate. Now, the two programs the government does have some control over, Medicare and Medicaid, it's true they do have some controls over it, but that is a relatively small segment of the marketplace. The vast majority of healthcare in this country is either provided by employers or it's provided by insurance companies who sell policies now on the exchange or the individuals. This is not a government-run, it's not a government-controlled system.
Your response, Paul.
In the U.S., healthcare spending now, after the ACA, is about roughly split 50% between the private sources and public sources, public programs. When you look, and I've got this, this book here, which I highly recommend for any people who are intent on punishing themselves. But it's really interesting because it's about how every country in the world, it's called the Fourth Revolution, is trying to get a hold over healthcare spending, government spending programs. Countries like Sweden, Finland, others, these Nordic countries that I think have a lot of admiration on the left are actually moving to get more competition and choice. In France and all these countries are saying, let's have for-profit hospitals, let's have hospitals compete based on outcomes, let's have people have more financial control over how they spend their dollars, because competition and choice is the only way we know of to get these costs down over time. So this isn't necessarily a left-right issue. It's actually about efficiency. The one virtue that markets have over government is things go out of business. People go out of business. Businesses can fail. They're not nobler, they're not smarter, they're not better people, but that's a market discipline that a lot of government programs and government functions don't have. You know, like in New York, we've had a lot of trouble with failing public schools. They don't get closed. So holding people accountable in public systems is very difficult. At least the market gives you a mechanism to do that.
This question, we'll give you a chance to, or you can keep those comments, make a note for them in the close, if you would. The question then was addressed directly to Paul. What is your solution for the people with pre-existing conditions without the ACA, and how would they be affected with what you referred to as some sort of a separate plan?
Right. You know, again, I give credit, you know, that for that population, the ACA is a win. I've always said, look, there are winners and losers. Every government action has winners and losers. What I would say is, what we should do is let prices float for younger and healthier people, charge them actuarially fair premiums, so they have low expected health expenses, charge them low premiums, get them into the market. For people who have pre-existing conditions, there are a couple of things you can do, one of which is to create what's called a high-risk pool, where you're going to say subsidies are going to flow to these people with the following healthcare conditions, cancer, diabetes, whatever. Or you can say to the people who are operating in the market, the companies, there's going to be something called reinsurance. So for really high-cost patients, the government will step in and say, we're going to cover 80, 90% of the cost of those people. That helps bring down premiums for everybody. Once you get younger, healthier people in the market, premiums fall, the need for subsidies falls too.
The problem with Paul's argument is that the high-risk pools existed prior to the ACA. This is not a new concept. They didn't work because, again, it was a subsidy, just like Paul says, and it didn't fundamentally address the population of people who had pre-existing conditions. The only way you can require insurance companies using the marketplace, which is what the ACA does, it's built on the marketplace, the private sector insurance marketplace. The only way that it works to provide insurance for people with pre-existing conditions is if you expand the pool, and so healthy people are paying into it. So that makes it actuarially possible for the insurance industry to survive and provide services for all people, no matter what their ailments are.
This question to you, first of all, John. As we're looking at different options, I believe that's where this question is going. Do you support Medicare being made available for younger people and/or Medicare for all? Maybe this gets to a distinction of Medicare and/or Medicaid through those government programs.
No, Medicare for all is Bernie Sanders. Medicare for all is essentially single payer, you know. And I think a lot of people would argue that if we could start after World War II, which is, you know, the reason why World War II is such a benchmark is because Germany, France, Great Britain, their countries were essentially destroyed by the war. So they had the opportunity to start from scratch on designing a healthcare system. It made sense. The problem in this country is that we have an entrenched private sector insurance and medical industry, and so trying to move to Medicare for all, which is what some progressives wanted prior to the ACA. I mean, John Conyers had the bill for years. He couldn't get a hearing when the Congress was controlled by Democrats because politically it's not feasible. Now, if Bernie Sanders had been elected president, that's what he was advocating, would have made a difference? I don't really think so. Because unfortunately, in a democracy, you have to accept the fact that very wealthy interests, in this case, the private sector insurance industry, they have tremendous number of lobbyists, they give a lot of campaign contributions, and they influence legislation. That's just a fundamental reality in this country. And so going to Medicare for all makes a lot of sense because we could move to more of a European system. We have cost controls on prescription drugs and a lot more control over medical procedures, the appendectomy example I gave you. But to get there is very difficult. We couldn't even get the public option, which was a part of the ACA, which was to have a government-run insurance program to compete with the private sector. We couldn't even get that past a Democratic Congress because Max Baucus from Montana, who was the head of a key committee in the Senate, wouldn't go for it. And so if you're talking about progressive social change
The time
or
has
enacting
expired.
any policy, you have to think about getting the votes and getting it enacted.
Time has expired. We want to give Paul a chance to respond.
Well, I certainly agree with John that you always have to start with the art of the possible in politics, right? You've got to start from where you are. There are always constraints. One thing that the U.S. does extraordinarily well, we're very, very good at medical innovation. We produce the world's supply of drugs, medical devices. Innovations happen here, and then the Europeans pick them up and they do apply price controls to them. It's basically the same as the U.S. defense umbrella, right, for NATO. The U.S. spends more on defense than everybody else, but they all benefit and we benefit from it too. If we suddenly cut our defense spending, Russia, China would step into the void. These other countries couldn't. But look, I think that again, there's no magic to the private sector. There's just competition. There's choice. I just support giving more money to individuals to help them make smarter choices with information, and then have the government, police fraud and abuse and make sure there's a safety net there for the most vulnerable people who can't afford it.
Paul, this next question then begins with you. This person's saying that you said that even if the ACA comes fully into effect, 27 million Americans will still be without health insurance. What do you base that claim on? It says, please elaborate.
Sure, you can look it up. It's a Congressional Budget Office report, long-term budget outlook for 2016. It came out last year. If you Google it, it'll pop up. This isn't me. This is the Congressional Budget Office, the nonpartisan scorekeeper for Congress. So, John pointed out, there are subsidies on the exchanges. About 80% of the people are getting subsidized coverage on the exchanges, but it tails off very quickly after about 200% of the federal poverty level, around $25,000 for an individual. Everybody after that is basically paying out of pocket. And so, the exchanges are just concentrating on very heavily subsidized people. Interestingly, what the Congressional Budget Office thought was that employers who were spending upwards of $20,000 a year on family coverage would just wash their hands of their employees and send them to the exchanges, which is how the CBO got its number originally, thinking that there would be 24 million people just on the exchanges. And it turned out that employers looked at the exchanges and said, gosh, this insurance is not attractive. We're not sending people to the exchanges because it's a business advantage for us to keep them. So the insurance there is really attractive to people who are getting really heavy subsidies.
My response is, yes, 27 million Americans don't have health insurance. Big reason is that the U.S. Supreme Court said that the expansion of Medicaid in this country, which was initially required under the ACA, then became an option of states whether to embrace the expansion of Medicaid. And Rick Snyder in Michigan, a Republican, along with the Republican-controlled legislature, agreed to expand Medicaid because it was the right thing to do, as well as it brought tons of federal tax dollars back to Michigan that we send to them. But there are about 20 states in this country have refused to expand Medicaid for ideological reasons, many in the South, So that's a fundamental reason why this 27 million is still out there. Second thing, again, the health insurance exchanges provide subsidies up to $97,000 for a family of 4 and up to $47,000. It is a sliding scale, and it gets less as you move up the scale, but still fundamentally it helps people out. And just to give you some perspective, in Midland County, 7,234 people have gotten health insurance in this county, which represents about 8.6% of the population, through the exchange or through the expansion of Medicaid. So it has a significant impact in Midland County. Kent County, again, 8.6% of the population has picked up insurance from both the exchange and Medicaid. And Berrien County, ironically enough, a county that Trump won, over 10.7% people in that county have now got insurance through a combination of the exchange and the expansion of Medicaid. So these programs work. They have helped to cover more people.
John, this question goes to you. Time did run a little long. We may give Paul some added time to respond to this. A claim that was made, principle of the ACA is that healthy people are more productive people. That was pretty close to the terms that you use. The question is then, why then is it necessary to coerce businesses into providing health care coverage?
Well, that's a great question. I mean, that's one of the best questions I've heard all evening. I don't think business, frankly, should be required to provide health care. Paul had it absolutely right. It became a function of the Second World War, and then it picked up its own momentum. And in the 1950s, when our economy was the strongest in the world, the percentage of employers providing insurance exponentially grew. That became the fundamental basis for providing health care in this country. But in the last 15 to 20 years, as American businesses come under tremendous competition with European businesses that don't have to provide health care because the government provides it, it provides an unlevel playing field, and American business have a harder time competing when their overhead is higher than their competitors around the world. I would argue that American business should not have to provide health care, but that means that we have to go back to the Medicare for All program. And ironically enough, General Motors has been complaining about the high cost of health care for years, $1,500 per car. But when it comes down to politically, whether they would endorse John Conyers' bill or endorse Medicare for All, they won't do it. So you have that disconnect there between whether business should provide health care or whether they're willing to get into the trenches and move to a Medicare for All.
All your response.
Sure. You know, about 90% of large employers, let's say 500 employees and up, offer healthcare in the U.S. Those that have enough capital use it as an advantage to attract employers. You know, John's right. The one thing I would say is this: I actually think General Motors is wrong, and most economists would tell them they're wrong too. Your entire benefit package, which means your pension, your salary, your healthcare, that's all the cost of employing you. Unless you think that General Motors could cut $10,000 from their employees' salaries and have those employees not notice, that can't happen. General Motors would have to turn around and offer them a higher salary in return, right? If you're competing for labor, that whole compensation package is what you're paying. The U.S. is a wealthy country. We're paying more than these other countries for labor. That really wouldn't change if you shifted to a different system because you still have to hire the labor. That's what I would say.
All right, Paul, we'll come back to you with this, and this gets down to the levels of coverage, what we had, what we have now, what we could expect if we see a change again. What patient protections can we reasonably expect, the question reads, the free market to produce to define what is a, quote, standard service? And why did we see so few protections prior to ACA?
Right. You know, it was an economist at the University of Pennsylvania, Mark Pauly, who wrote a lot about the individual insurance market. What he found, actually, and look, there were no doubt there would be people being turned away or charged higher rates because they were very sick. If you're subsidizing those people, in other words, an insurer has no problem covering a sick person if they can collect enough premiums to cover that person, right? They're indifferent about whether or not they're sick as long as someone is paying for it. So I think that, look, what we ought to do is send a lot of these decisions back to the states. You could say, look, under the ACA, we've created this system. There's this expectation these people are going to have coverage. Here's the amount of money we're going to get for Medicaid for low-income people. Here's the amount of money you're going to get for subsidies. We're going to hold you responsible for getting better bargains with your hospitals and your doctors, for reforming your provider licensing laws, doing all sorts of things to get more transparency. Right now, you know, John said it, Michigan has an incentive to draw down more dollars. Those are coming from somewhere. All that money is coming from somewhere. It's coming from other industries that might be more productive, that we might want to have more money going into them as opposed to healthcare. There's no such thing as a free lunch. And economists will tell you, look, healthcare productivity is low. The more we send money into less productive industries, the less money there is available for other industries, for other innovations, and more jobs.
John, your response.
You know, I go back to my initial principle. It doesn't matter how you frame the bill, it's only the outcomes that matter. You know, I've been listening to Paul's rhetoric about economic theory and the study in that study. The bottom line is that prior to the ACA, people with pre-existing conditions had extremely difficult time getting health insurance. Sure, if you're wealthy, you could get it, but if you're a middle-class working person with diabetes, you were in a world of hurt. If you were a female, how many women are in this room? The insurance companies prior to the ACA discriminated against women where they would charge more for women at the same exact age as a man and the same health status. It's simply because you're female. Is that right? The answer is no, it's not right. Is it fair that the insurance companies be allowed to drop coverage just because you get sick and you've been paying your premiums all these months and years? Is that right? No, it isn't right. Is it fair that you have a lifetime ban on payments? No. The ACA says that we have to treat people fairly. We have to provide the means that everyone can get health insurance. It shouldn't be a function of your class. It shouldn't be a function of income, because we want people to be happy. We want people to have the ability to go see a doctor when they need to.
Two more questions then before we turn to the closing statement. So it will be the question and the response, and we'll go to you, John, since the response was yours. You get the first crack at this, and this goes to you, some of your opening remarks. The question reads, and I quote, "Since when is it the government's job to make sure everyone has health care? Since when is having health insurance a constitutional right?"
I wouldn't argue it's a constitutional right. But the reason why it's important that the government get involved is that the fundamental reality is that everyone gets sick. Everyone, as you get older, gets sick. We have a dysfunctional healthcare system in this country prior to the ACA, and I'm not saying it's perfect now by any means. But the fact of the matter is, with close to 50 million Americans not having health insurance, that means you throw the entire system out of whack. Because, again, hospitals have to provide care for people without health insurance. They pass the costs on to people that have health insurance. And so in order to fundamentally try and address this industry, you have to tackle both expanding coverage to everybody, so everyone's paying into the pool, and then you also then have to take the responsibility for helping to guide the system moving forward. Final comment is that, the ACA also has a couple of new institutions in place to try and address innovation and try and address fraud and those types of things, which we haven't talked about. So the ACA is not simply about expanding coverage, it's also about addressing the high cost as well.
Paul, your response.
Look, the ACA does have some pilot programs. A couple of them are having effect. There's something called preventable readmission. So if a hospital, and something like 70% of Medicare readmissions are somebody goes into the hospital, somebody comes out, and then they go back in a week later. And Medicare has put payment penalties through the ACA on hospitals that do this. It does appear to have reduced these readmissions. It encourages hospitals to coordinate. You didn't need the ACA to do that. There's a lot of stuff that's in the ACA that Medicare could have done anyway, and should have done anyway. I think what we need to think about is, if Medicare says we're going to give you like a 1% payment bonus if you reduce your basket price versus X, what it used to be. What's happening nationally is hospitals are consolidating and raising their prices by 6, 7, 8, 10%. So I think that the problem here is that in a market where consumers don't know what the quality and pricing of hospital is and don't have an incentive to seek out, and the hospitals don't have an incentive to seek out people and say, come to us, we'll give you a lower price. Come to us, we'll deliver better care. That's the incentive that you get in a market. So I think those are the big meta things. Government can still do all these experiments. Government can still say, look, we're going to subsidize these people. But the market can be the mechanism that we have progressive values. I think there's no conflict when you think about what we need to do for low-income populations and the value of getting more care, more high-quality care to more people.
And Paul, final question to you before we get to the closing statements. This was not addressed directly to you, but I'm going to send this question your way first because it does get at one of, I sense, the fundamental differences between the arguments that both of you have presented. This one does address specifically the health care provided by the Veterans Administration. And it reads, we already have government-run health care called the VA, and I will use this exact quote, how's that going?
Not terribly well. And veterans are a special case, right? A lot of them also have private coverage. So, the people who can often get private care, and maybe they go to the VA for some things. But we've heard over the last 2 years, look, all these stories about VA waiting lists and poor quality of care, people dying while they're waiting. That's the problem with these systems, is that what's the check? Where do you go if you can't go anywhere else other than the VA? Right? Now, one reform would be to say, we're going to give you this much money, you can go private insurance, or you can go to the VA. Let the VA compete. right? Actually, under the Clinton administration, VA had a very good administrator and improved its EHR systems, did a lot of interesting things. The administrator left, they go down. That's what happens in administered systems. If you have really good leadership, really good organizational leadership, you can keep that going for a while. But if there's no market pressure, why keep it up? So I think that, look, we need all sorts of experiments. We need supply side, people doing different things in terms of primary care and nurses getting involved. Those are all great. And we need demand side reforms. We need people who know where the quality is, what the price is, and have an incentive to seek out the people who can do it more efficiently than anybody else.
I would agree that the VA has had a mixed history, but I would disagree with the argument that you need I would agree that you need great people running the VA system. The problem with the argument is that you get some lousy people in the private sector system as well. And remember, the corporate executives of these private sector insurance companies were the ones who decide not to provide insurance for people with pre-existing conditions because they can't make a profit on those kind of people. The VA system, the Medicaid system, Medicare system were all enacted because the private sector refused to provide coverage for those constituencies of people. So the private sector insurance system is not going to save us all because soldiers get hurt seriously. So we have to have government run insurance. The VA also, however, has very low administrative costs. So the quality of care has to be improved, but the cost of providing it is much more efficient than the private sector is.
I'd like to take the opportunity to once again thank Professor Glenn Moots for inviting me to participate, to both of the guests for their very good exchange. And so in applauding Professor Moots, the program here at Northwood University, and both of our guests, would you please applaud and also add into that yourselves for all the questions that you provided as well. And what I will do is I will yield. Both our guests have an opportunity for a closing statement. 8 minutes is still, that's all right. And what I will do is I will step aside. The opening statement first came from John, so he will have the second of our closing statements, and I will yield the stage then and the podium, first of all, for his closing to Paul Hoppe.
Thank you. John and Glenn, I appreciate all the commentary tonight, all the engagement, and certainly I applaud a civil, smart debate. We need to have more of these everywhere, certainly in Washington, D.C. We could all use forums like this to improve the quality of our policymaking. I just want to make one quick point before my remarks about administrative costs. Private companies, private insurers like United Health actually administer Medicare claims for them. So the argument would be something like this. United Healthcare has enormous administrative costs that it has no incentive to try and control, despite the fact that if it cut down on administrative costs, it'd have higher profits. On the other hand, when it's working for Medicare, somehow it finds a way to just jettison all those administrative costs. What Medicare doesn't have that private insurers have is cost utilization controls. So all the things you actually want Medicare to do, which is say, these providers are in network, you're not in network. We're paying for this service, not for that service, is something you'd actually need to do if you want to improve Medicare quality. Again, Dartmouth University has looked at years and years of Medicare data and said there's this enormous cost variation that have nothing to do with quality. Insurers, if they want to make a profit, have an incentive to have that under control and try to get higher quality. The fact that the VA doesn't have higher administrative costs actually tells you they're not doing a lot of things that could improve the quality of their care, hence the waiting lists, hence the problem with people dying waiting for care. That's actually something you need to spend more on preventing. I'm not saying that government is going to just walk away or that we walk away from the poor or that we're not going to provide support for these people. I'm not saying that at all. But the problem actually with government right now is that, and speaking of the corporate lobbyists, government is where they go to get protection from competitors, okay? In 1974, the federal government, Medicare, told all the states to pass something called Certificate of Need laws. What is this? This is where a hospital would have to go to a state regulator and make an argument before they built a new wing on their hospital or offered a new high-tech service like oncology and radiation. The idea was if we control supply, they won't start building and then raising their prices because they built everything. What actually happened in point of fact is the hospitals captured the regulators, and when a new competitor wanted to come into the market and try and offer a service and beat them on price, they said, no, you can't. And they challenged them at these commissions and fought them off. And again, 80% of the metropolitan areas in the US, highly concentrated, not according to me, not according to the conservatives, according to the US Federal Trade Commission under both Republican and Democratic administrations. The FTC has said these certificate of need laws create barriers to entry and expansion, limit consumer choice, and stifle innovation. And the evidence to date does not suggest that these laws have succeeded in controlling costs or improving quality. The behavior of for-profit and non-profit hospitals is exactly the same. The FTC's acting chair wrote in 2015, the charity care claims made by hospitals on behalf of con laws appeared to be little more, and I'm quoting here, than an argument of convenience by politically powerful special interests attempting to protect their historical government perks. Okay? It's not the corporate evil bad, government noble angels good. We all use the same kind of units. They're called people. Okay? They have behaviors, they have incentives. And you have to understand those incentives and create systems that encourage them to do better. Hospital safety, again, deeply disturbing, right? Medicare, Medicaid, all these enormous government programs. Hospitals, 200,000 people die every year in hospitals because of preventable errors. Again, what other industry would we tolerate this in? Look at car quality, right? The highway, the Federal Highway Commission doesn't give you federal subsidies to buy cars. It regulates the quality of the cars. It said you must at least have these airbags, these safety features. And so industry competes and the cars get better. The cars today are higher quality and adjusted for quality cheaper than they were 20 years ago. The basic model of car has safety features you couldn't dream of, collision avoidance, automatic braking, couldn't dream of 20 years ago. If we want to get serious about these things, get serious about repealing the regulations that prevent competition, certificate of need laws, provider licensure. States tell nurses that they have to practice with a physician overseeing them, right? Tells people who has to do what and what they have to charge. That is a recipe for high costs. Strip away those regulations, but go naked on cost and quality. Give people incentives to seek out that information and use it. Can we radically slash the cost of American healthcare and make healthcare affordable, even to the poorest Americans, again, with subsidies from the government? Well, I would look at one of the poorest countries on earth, India, for an example about how to do that. Indian innovators have opened world-class cardiovascular hospitals that do cutting-edge cardiovascular surgery for a fraction of the price in the US or Europe. They do the same thing for cataract surgery. These are the poorest of the poor. How have they brought prices down to the point where even poor people can afford it? They use nurse practitioners. They use people who have less training but can do 85% of what physicians can do. They run their surgery centers like a Toyota production plant, where a physician will be operating on one patient and then turn around and operate on the next patient. They're incredibly efficient and effective, and they drive throughput. So compared to US surgeons that might do a few hundred surgeries, they do thousands every year. That not only makes them better surgeons, it drives down costs and raises efficiency. And this is compared to any other US outcomes. There are companies that are starting to think like this. Lowe's and Boeing have contracted with the Cleveland Clinic and said, we're going to send people from Seattle or wherever our companies are, wherever our factories are, we're going to send them to the Cleveland Clinic. Cleveland Clinic is going to guarantee the price and guarantee the outcome. And if they do something wrong, they'll pay for it. We need these national markets. We need states, who are often the largest employers of their states, to start acting like responsible stewards of their taxpayer dollars, not as partners of hospitals, not as people who protect market share, not as the idea is to draw down more federal dollars to my state for an industry that's too expensive. Again, if you spend more money on inefficient care at a high price, you're not being efficient. You're actually not doing any of these people a favor. Healthcare costs have outstripped wage growth. Compensation, total compensation for American workers has actually gone up by quite a bit. But an increasing share of it is eaten up by health insurance premiums. That's money that's not going into your pocket, or your kids' pockets, or your parents' pockets, that we could spend on other things. Health is valuable. Health insurance is a tool for protecting you against rare financial accidents. Get the incentives right. Promote competition and choice. It's not an either or. It's not a partisan issue. It's just good policy. Thank you.
In 1993, President Bill Clinton attempted to move healthcare reform in this country, and he failed. At the time, there were 35 million Americans that lacked health insurance, but he failed. Fast forward 15 years, and an additional approximately 15 million people lost health insurance, so it's close to 50 million people. Barack Obama moved a bill to expand healthcare coverage. He did that by building upon the current system in this country, the private sector insurance employer-based system. And so he is attempted to have more competition within the marketplace by establishing the exchanges. On the last page of your handout, you should understand that the ACA helps all of you. The ACA says that young adults who previously, prior to the ACA, had a large percentage were uninsured. Sure, you're healthy, but what happens if you break a leg snowmobiling or skiing? You rack up serious costs. If you don't have insurance, you're in a world of trouble. What does the ACA do? The ACA says now you can remain on your parents' policy until the age 26. You no longer have to worry about not having health insurance, but it also helps you find a job once you graduate from college, because your employer doesn't have to provide health care for you, so he might be willing to hire you in an entry-level position. It also enables you to start your own businesses and become free agents, because you don't have to worry about health care because you can remain on your parents' policy. And I think that's a tremendous asset that young adults can take advantage of because of the ACA. Finally, you know, it's fascinating that the affordable health care is not something that, the model of this healthcare system is not new. The Heritage Foundation back in 1992 proposed a healthcare proposal called the Heritage Consumer Choice Health Plan. As you all know, the Heritage Foundation is a very conservative think tank in Washington, D.C. Stuart Butler, who was the healthcare expert, testified in 1993 in front of Congress saying, individuals and their dependents should be required to enroll themselves in at least a basic health plan that at a minimum should provide the rest of society from large and unexpected medical costs occurred by a family. Once he made it required everyone gets insurance, he would then regulate the private sector insurance market to provide a basic package of benefits, which is exactly what the AC does. And then he goes on to say, to the extent that a family cannot reasonably afford basic insurance, government should take responsibility for helping people to buy the insurance. So this is the conservative think tank that came up with this plan. Newt Gingrich, the conservative Speaker of the House, in 1993 on Meet the Press says, I am for people exactly like car insurance, requiring having health insurance and be required to have health insurance. And I'm prepared to vote for a voucher system which would give individuals on a sliding scale a government subsidy to ensure that everyone as individuals has health insurance. In 2007, Newt Gingrich says that citizens should not be able to cheat their neighbors by not buying health insurance, particularly when they can afford it. So the bottom line, we'll go one step further. He worked for Governor Romney when he ran for president in 2012. You know what Governor Romney enacted in Massachusetts when he was governor? He enacted health care reform, which requires people to sign up for insurance. It was mandatory. They provide financial help for people to be able to afford it, and it had some increased regulation of the insurance industry within Massachusetts. It was a very effective program. Insurance coverage expanded, and the uninsured went down by approximately 2/3. This is the model for the Affordable Care Act. So the Affordable Care Act can trace its roots back to the Heritage Foundation back in 1992, and then they looked to Mitt Romney as governor that, in fact, that theoretical plan by the Heritage Foundation, which Mitt Romney adopted, in fact worked. And the irony, of course, is that when Mitt Romney ran for president, he distanced himself from the most effective program, and I would argue the most effective accomplishment he had when he was governor. So the bottom line is that I go back to my initial principle. I look at the outcomes and see what the result is. We now have 20 additional million Americans that have health insurance. I don't understand this notion, that people would rather have money outside of their health that Paul was talking about. I'm paraphrasing a little bit. The bottom line is that everyone needs health insurance, and it's not just for emergencies, it's for basic fundamental visits to your physician, for your doctor, for any specialist, for any test that you need. Because if you don't have health insurance, the cost, and he's right, the cost is high. And he's right, we also have to address that cost, which the ACA does address, and he acknowledged that it does address it. But the bottom line is that if you don't have health insurance, then you fundamentally are not in control of your health, your family's health, your children's health. You're at the mercy of clinics and the emergency care at hospitals. And so the reason why the ACA is so necessary for this country is that, in fact, it's making a huge step in the right direction to not only enable all Americans to be able to become equal. We're fulfilling Abraham Lincoln, that we're dedicating ourselves to addressing a major social and economic concern. And most fundamentally, we're improving the quality of life for these individuals. Just think about your own individual self or your family. If you didn't have health care, you all have gotten sick at one time or another. What would you have done if you hadn't had the ability to go to a doctor to get care promptly when you needed it? You know that your quality of life would suffer. And this is what happened to a huge chunk of the American population. And the frosting on the cake is that when Paul talks about these federal dollars and federal subsidies, this is federal tax dollars we send to Washington, D.C. every April 15th. We just did it recently. That we're getting back into Michigan. And that money now is being used to provide health care, but it's also used to stimulate the economy because we're putting together more people to work, more doctors, more nurses, and more of the industries that benefit from healthcare expenditures. Is there more work to be done on the ACA? Absolutely. And the Democrats in Washington, D.C. have made it crystal clear that if President Trump and the Republican leadership in the House and Senate, if they sincerely want to build upon the ACA and make improvements, then the Democrats will work with them. Because we all acknowledge that we can always make a system work better as we gain experience. We've had 7 years experience now with the ACA. It's proven effective. Can we make it even more effective? Yes, we can. It just requires people that care about people to work together in a civil manner and in a sincere way as well. I really thank you for the opportunity to be here. I hope you've all learned from this experience. And again, feel free to follow up by email if I can be of any help down the road. Thank you.